Peter Merkel. I direct the Vasculitis Center at Boston University, where I've been for quite a while, and I also direct something called the Vasculitis Clinical Research Consortium, which is an international research group that you'll hear more about throughout the meeting, etc. And I have had the great privilege of working with all the speakers that we'll have, almost everybody actually at the meeting, certainly all the ones today. And I think you'll find that we're a group that gets along well, which is why we've been able to advance research. So I'm going to talk to you about vasculitis. So this is it. Introduction to vasculitis, a family of diseases. I'm going to start with a case, because we're here to talk about patients. We're here to talk about how we can help patients, how we can help understand what's going on with them better, and how we can treat better. This is I've anonymized to some extent, but this is a patient of mine, and it could be a patient of any of the physicians here. This is unfortunately a common story. Ms. L was a 40-year-old woman when I first met her. Young, very young. 40-year-old woman presented with medical evaluation for shortness of breath. She had several weeks of symptoms. She had a red eye, which is called episcleritis in this case. She had sinusitis. She had a runny nose and rhinitis with nosebleeds. She had red skin lesions, what we call purpura. She had progressive shortness of breath. She was treated for pneumonia twice with antibiotics. And not surprisingly, since that's not what she had, she did not get better. She was transferred to Boston Medical Center, our hospital, and she then began to cough up blood, which is hemoptysis. She had red blood cells in her urine. Couldn't see them. Couldn't see them until you went under the microscope. She had something called CAS, which is a bad sign in the kidney. And her kidney function test was slightly abnormal, but still abnormal. She had a positive test for ANCA once we went around to testing it. This is her X-ray, and what you can see here is this is a bad-looking X-ray. Most of that white stuff on the right side, your right side, which is the patient's left side, is blood. This is blood filling up. I think I have a pointer here. Oh, I do. Does that show up there? Oh, look at that. Okay, so all of this is blood filling the airspace. It should be dark like that. There's blood here as well. This is pulmonary hemorrhage, bleeding in your lungs. She was literally not getting the oxygen into her body because the blood was blocking it. This is a CAT scan showing the lung filled with something, and in this case it's blood. We did a kidney biopsy which showed glomerulonephritis, inflammation and some destruction in the kidney. Not good. Even though kidneys didn't look like they were doing that badly, they were not happy. She was diagnosed with ANCA-associated vasculitis with granulomatosis, or Wegener's. There's a whole issues with the name. We can get to another point. And we instituted therapy. We gave her high doses of glucocorticoids, steroids for 3 days, IV, and then gave her oral prednisone. We gave her cyclophosphamide, also known as Cytoxan, a chemotherapy drug, orally every day. And we gave her antibiotic to prevent certain infections. She did great. Her lungs cleared up like that. Her eyes got better, rash, everything. Her nose got better. She felt much better. Her kidney function returned to normal. This is her X-ray just 2 weeks later. It's a normal X-ray. The blood is completely gone, and she felt fantastic. She also gained about 40 pounds, which she did not like and still does not. She lost a lot of hair, although it grew back. She became menopausal. She stopped having menstrual periods, and they've never returned, which is not good in general for her health, that have done relatively early. We switched her from cyclophosphamide to methotrexate, and then she was on it for a long time, and then she had a flare again, a recurrence 18 months later. We then gave her steroids, glucocorticoids, again with cyclophosphamide. She did well for 2 years then on azathioprine, which is the drug we gave after cyclophosphamide. And on that drug, she flared again. And we had to give her yet a third course of cyclophosphamide, and now she's on mycophenolate, which is Celsep. So what does this, she's doing pretty well, but she has suffered from the drugs and from the disease. What does this case tell us? This case tells us that the delay in diagnosis is common, altogether too common. Several weeks in her case, several months in some of your cases, I think, for all our different forms of vasculitis. We are having a session for physicians tomorrow, a new thing, just for physicians. We're educating. It's part of our movement. All of us do a lot of these lectures to try to help physicians learn how to diagnose and treat earlier. This is a life and organ-threatening series of diseases. Not always. Sometimes it's mild, and many of our patients do very well, but it can be very serious. Remission is obtainable. Remission, meaning no active disease, is the goal. It is expected for all of our forms of vasculitis. But relapse is very common. Relapse meaning disease comes back either early or late. Therapy is toxic. We give drugs that work but have a lot of bad side effects, and we need to get away from that if we can. So we're doing well. We're doing much, much better than 20 years ago, and much better than 40 years ago, where there was very little hope for some of the cases, although not all. But we need to do better. Would the new treatments we're going to talk about this meeting have changed these things for Mizell? Perhaps. So what is vasculitis? Well, it's any of a spectrum of relatively rare diseases involving inflammation, leaking, or destruction of blood vessels, with resulting damage of the tissues and organs supplied by the affected vessels. And because blood goes everywhere, vasculitis can involve virtually every organ system, although each syndrome has unique aspects. Basically, think of it as plumbing. If you don't have the blood and oxygen going someplace, whatever's downstream is not happy. But it's a bit more complicated than that. Some key points to remember is these are rare diseases. They're all orphan diseases in the United States, and similarly labeled as such in Europe, for example. That means that in the United States there are fewer than 200,000 patients with any one form of disease. Being an orphan disease gives a little specialness at the FDA, but it also means companies are a little less inclined to do research because it's rare. There's often a delay in diagnosis. I already told you it's a serious disease. It can involve everything. We tend to be aggressive. We treat with pretty strong drugs for many types, but not all types of vasculitis, and relapses are common. Why is there such a variation in vasculitis? Well, this doesn't even completely do justice, but the variation in size of blood vessels, arteries, is huge. So you have an aorta coming out of your heart, which is huge vessel, goes up, goes all the way down into your abdomen. Then everything branches off until you get down to the microscopic size vessels in your skin or in the kidneys or in your eye, capillaries that are everywhere. And there's different forms of vasculitis, hits it all along the vascular tree. So large vessel vasculitis hits the aorta and its branches. Medium vessel does medium, and small vessel is small. It's not that clear. There's a lot of overlap, but now you can see why there's such a variation in vasculitis. Here is a list of different vasculitides, sort of by vessel size, which is not perfect. We're actually looking to new ways to classify, but it is a very helpful way to think about it, with the small vessel vasculitides listed there, the medium ones, the large vessels, and then those that don't have any predominant size that are sort of all over the place. Not a perfect system, but it helps the clinicians get it in their mind, and it helps patients as well. So why do we lump all the vasculitides together? Why are we the Vasculitis Foundation when we used to be the White Granulomatosis Association? And there's a variety of reasons for that, but one is that the vasculitides have lots of things in common for patients, for scientists, and for physicians who treat the patients. The pathophysiology, what causes the disease, what's happening at the level of the body, inflammation of the arteries, the vessel damage and destruction, similar across the different types of vasculitis. There's overlapping clinical features. Church-Strauss has nasal and sinus stuff, so does other forms, et cetera, et cetera. You can see skin, you can see nerve involvement in all sorts of different types of vasculitis. We treat in a similar but not the same fashion, but many similarities across in terms of treatment with prednisone, vitamin P, way too much of that. How many people here hate prednisone? All right. You're a wise group. But it's a great drug because it works quickly. But the immunosuppressive agents, we use similar treatments across the different vasculitides. And these are kind of rare, weird, and misunderstood. And I mean that about the diseases, not the patients. Although it could certainly apply to the physicians as well. And because they're sort of these orphan diseases, you lump together from a scientific standpoint and from a clinical standpoint and almost from a practice organizational standpoint. And for all these reasons, it makes sense to study them together and learn from one to the other. And that's what we do. So who gets vasculitis? Well, there are certainly differences. Different forms of vasculitis occur in different types of people. So giant cell arteritis occurs extensively, almost only in older patients, the 60s and especially the 70s and 80s, while Takayama is usually younger. HSP, much more common in children that's Henoch Schönlein purpura, than in adults, although it occurs there too. Some are more likely in Caucasian, some are more likely in other races and ethnicities, but everybody is subject to some form of vasculitis. And around the world you see vasculitis. What causes vasculitis? That may be your first or second question after, how do you pronounce that? The answer is we don't know. For most types, we do not know what causes vasculitis yet, but we're working on it. Some drug-induced disease or infections, we do know that they can cause vasculitis. But for most, we don't know, but we think there's some sort of combination of autoimmunity, meaning your immune system is fighting against yourself, instead of infection, it's fighting against yourself, or it's an infection. We don't mean a direct infection, but maybe an infection years ago that turned something else on in your immune system, and now it's coming back to haunt you. People like to think about environmental exposures and toxins. That is popular thought, could have been my sick building, could it have been I was exposed to this. We haven't actually found good evidence to support that for any type of vasculitis, though we continue to wonder about that in different circumstances. Remember that almost no people are all exposed to the same thing, so it would have to be something rather common. Are genetics involved? Maybe. We're doing a lot of work in genetics, a lot of exciting work and research in genetics, and many of you have perhaps given your DNA to be studied. Because not that we think it's like cystic fibrosis or sickle cell anemia, which is a single gene that you inherit and you get a disease. But it could be that a certain genetic makeup makes you more likely to get it or more likely to get kidney disease as opposed to brain disease, etc. And we may learn from that as we are learning in other diseases. Almost certainly, it's a combination of all of these things or something else we haven't thought of. But that's where we're going with this. So here's another way to list it. This is I like to put this list up. It scares the medical students. But there are a lot of different types. It doesn't even list all of the different types of vasculitis, but certainly the main types. And you're going to hear these names over and over again. You're going to hear some more commonly than others, and it may not be yours that's the most common, mostly because we try to use at the symposium, we try to give you the best data that's available. And the best data is usually in the slightly more common ones. On the other hand, we sometimes borrow our understanding from one disease and hope that it helps understand even rarer form. And so that's what we're trying to do. And I think what you'll see in the last 15, 20 years is there's been a spread that research is now happening in more and more types of vasculitis. But it takes time. Let's talk about the group for a second. Evanco-associated Luis Felipe Flores-Suarez is going to tell us about that in just a moment. Wegener's microscopic polyangiitis and Church stress, we often lump them together because they have lots of overlap, but as he'll tell you, they certainly are each unique diseases and need special attention. So he'll talk about this. I'm just going to show you, these are all the things that can happen in the patients with these diseases. So it's an incredibly variable disease. And I'm not going to go through all of these. Some of you have some of these things, unfortunately. When you talk about the other small vessel vasculitis, they get some of those things on the list, but not all of them. But they get things like purpura. This is inflammation and breakage of the blood vessels in the skin. It's a very common finding in many different types of vasculitis. If on the skin, we can see it, we can biopsy, it's nice. If it's happening somewhere else, we might not see it for a while, might not be so good. If it's happening near your nerves, inflammation of the blood vessels around the nerves, this person can't lift his or her wrist. That's a wrist drop, not good. Very painful, very disabling. These are the kinds of things that happen in small vessel disease, can happen in other types as well. Just a sampling here. This group of diseases, Behçet's disease is an unusual disease that is much more common in the Mediterranean area, in Turkey and Iran and Iraq and in Greece, where you get ulcers of the mouth, of the genitals, you get skin problems, you get lung problems, you can get brain problems. It's a different form, more common in other parts of the country, other parts of the world. Polyarteritis nodosa has been known about for years and years. Medium vessel, I'll show you something on there. We have some sessions on that. Kawasaki's disease of children, and thromboembolitis obliterans question is vasculitis as opposed to a vessel problem. That's a little different.